who is rounding the newborn nursery. She had just, sorry, Dr. Chan had just emailed us having some internet connection issues. She's working on it again. If you are interested in having someone in your practice join the Pediatric Executive Committee, please reach out to me. We'd love to have medicinal from our community pediatric practices. Also, Dr. Katherine and I are continuing to visit community pediatric practices in person and or virtual to provide more information regarding our inpatient pediatrics program. So if we haven't made a visit to your practice and you're interested in learning more about us, please let me know as well. Also, I know everyone's been hearing a lot about COVID and potential increase in pediatric patients and admissions. Thus far, we haven't seen an increased number of pediatric patients presented with COVID-2 REX, but they are seeing more at the medical center. Because this is something that's forever changing, wanted to give you an update for the COVID-19 visitor policies. And so this just was in effect this week for pediatric patients. It's unchanged, but patients may have 3 visitors in total. They can have a parent, guardian, and another person. They can only have 2 visiting at one time. There also are 2 parents or guardians who were allowed to be with a surgical patient in the area preoperatively in person. And then for the Women's Center, patients may have 2 visitors. If a mom does have a doula, they're considered one of the 2 designated visitors. For COVID-19 positive mothers, they're allowed to have 1 asymptomatic visitor who is supposed to stay in the room the entire time. And then for babies who are in the NICU, only parents or a second support person will be allowed in the NICU. And if you have a family who surrogates, they may have 2 visitors. Once the baby is delivered, they're then a pediatric patient and they can have 2 parents or guardians who are present. So this was sent out in an email, so you don't have to memorize all those, but just so that you have heard it again. And then also wanted to recognize REX has had a number of awards and recognitions for 2021. So they were awarded the Leapfrog Grade A Safety Guide for both fall and spring, Joint Commission accreditation. This year, CMS 5-star recognition, Magnet recognition for, I believe, the 4th time, Best Maternity Hospital for Newsweek, World's Best Hospital in Newsweek, Best Hospital in the State by Business North Carolina, and Top Hospital Award for Quality and Safety. So very appreciative of all the hard efforts of folks throughout the hospital that have made this possible. Let me see if Dr. Chan was able to.
I am.
Yay!
Good Hi, morning. Thank you for your patience. I had some internet issues, but we worked it out.
Welcome. Well, I was just going over some department updates, and I'll give you a quick introduction and we can go ahead and get started with your talk.
That sounds great.
So this is Dr. Chan. She is an associate professor of urology and the director of the Pediatric Kidney Stone Clinic, as well as director of pediatric urology research. She is a diplomat of the American Board of Urology and is board certified in general and pediatric urology. She specializes in pediatric urology and is an expert in the surgical treatment of hypospadias, undescended testes, and kidney stones. And she brings her expertise in stone management as the director of the Pediatric Kidney Stone Clinic at UNC. So today she's going to talk to us about antibiotic prophylaxis in pediatric urology, and I will turn it over to you.
Okay, thank you so much. I appreciate the kind introduction. I'm going to share my screen. Here we go. Are you able to see that? Okay, wonderful. Thank you so much. So as Dr. Lewis said, I'm Dr. Chan, and I started here at UNC in April of this year, so I'm relatively new. I was in practice in Indiana at Riley Children's Hospital for a little over 7 years prior to coming here. So I'm very happy to be part of this wonderful department. So we'll be talking about antibiotic prophylaxis in pediatric urology, which is a bit of a controversial topic, as I'm sure you know. And I wanted to mention that I have no financial relationships with any eligible companies, so no disclosures at all. The objectives of our talk are threefold. So first, the objective is to understand the evidence both for and against antibiotic prophylaxis, and we'll be focusing on 2 conditions primarily. Those are patients with prenatally detected hydronephrosis and also those with vesicoureteral reflux. Second objective is to understand the risks associated with antibiotic prophylaxis, particularly the antibiotic resistance, which is a question I get a lot in clinic, and I'm sure you do too. And then finally, we want to understand various factors to consider when selecting a prophylactic agent if you chose to put a patient on prophylaxis. Okay, so this is our team. We now have 4 people, soon to be 5. I'm very excited to share with you that we have another pediatric urologist starting with us on Monday next week. His name's Dr. Hans Aurora. He'll be coming to us from Lurie Children's in Chicago, where he's finishing up his fellowship. So Dr. Ross, pictured there next to me, is our division chief. I'm sure you guys know her well. So we have a wonderful team. And I also wanted to mention we are expanding access to care throughout the state for the children of North Carolina. You may or may not have heard rumors of another site in Wilmington. So I can tell you for sure we will be going to Wilmington. Dr. Ross will be the first person heading out that direction for clinics starting in either September or October of this year. And we will all eventually be going out there as well. So we also see patients, as I'm sure you know, at Blue Ridge Clinic right across the street from Rex, which we love. We go down to Sanford. We're, of course, in Chapel Hill, which is our home base. And then we do see patients at Hillsborough as well. Okay, so this is a little bit about me. I went to college in the Midwest in Indiana. I went to medical school at St. Louis University, did my residency at Case Western. I trained at Boston Children's Hospital for pediatric urology. As I mentioned, I was at Riley Hospital for about 7 years, and I just got to UNC back in April. I think Dr. Lewis went over my various titles and roles, and responsibilities, and all that. So as far as this talk is concerned, I mentioned we're discussing 2 conditions primarily, reflux and hydronephrosis. I will spend the most time on the RIVER study, which I'm sure you're familiar with, that came out several years back. We'll talk about antibiotic resistance and also agents of choice. And then we'll talk about the Society for Fetal Urology guidelines regarding prenatal hydronephrosis, and also a newer classification for urinary tract dilation, which, as you may have noticed, is used by the pediatric radiologists at UNC. Not necessarily widely used outside of our institution, though. So a lot of people are still using the SFU classification system, and I'll mention that as well. And please feel free to jump in with questions as I go. I want to make this interactive, and we could certainly take questions at the end too. And Dr. Lewis, how much time do we have, just to clarify? We go until 9, is that correct?
Go until 9, yep.
Okay, just making sure. Okay, so reflux, a condition I'm sure you're familiar with, goes from 1 to 5 on the grading scale. This is a diagram I like to show parents in the clinic, with 1 being just into the ureter and 5 having a moderately, dilated and tortuous ureters. You can see there in the lower right. So children with febrile UTI may have reflux, as you know, and our goal is to prevent recurrent UTIs in children with reflux because of concerns about potential renal scarring after multiple UTIs. However, antibiotic prophylaxis is quite controversial, and there's been a lot of mixed evidence regarding antibiotic prophylaxis, both in favor of and against. So we'll start with the RIVER study, as I'm sure you've heard of. This was really the largest ever trial looking at this question of whether antibiotic prophylaxis is actually beneficial in children with reflux. And it was really the gold standard as far as trials are concerned. So it was randomized and placebo-controlled. There were about a little over 600 children enrolled. This trial ended in 2011. So it's been out for quite a while now, but there's really been nothing like it since then, which is why we still talk about it. It was a 2-year study through multiple sites in the U.S. Interestingly, UNC was involved in that study as a data coordinating center. I wanted to mention as well, in terms of who is enrolled, this is important because I think it speaks to how generalizable the data is. So does it really relate to your patients or not? So it included children with grades 1 through 5 reflux. They did not include, grades 1 through 4, my bad. They did not include grades 5, and I think that's probably because a lot of those children just end up getting surgery anyway. They're less likely to be on prophylaxis long term. The median age was only 12 months. That's interesting to note. 92% of the patients in the study were girls. So that's, again, interesting to note. Not very many boys in the study. They enrolled patients who were diagnosed after their first or second febrile UTI or symptomatic UTI. Their primary outcome was recurrent symptomatic febrile UTI, and they had very strict diagnostic criteria, which I think is a wonderful aspect to the study in terms of how the specimens were collected, the number of colony forming units, et cetera. I think that's been one of the criticisms of other studies and other guidelines too, that they weren't as stringent with the inclusion criteria and the diagnosis of UTI. Secondary outcomes were renal scarring, treatment failure, and antibiotic resistance patterns. One thing to note with the renal scarring is that the study was not adequately powered to look at the outcome of renal scarring. So just because it was negative doesn't mean that the association doesn't exist. So we'll talk about that in a little bit. So this is the largest and most rigorously designed study on reflux to date. And as I mentioned, they had stringent criteria for both the index or first UTI they were required to have for study entry, and also recurrent UTIs. They had an extended follow-up period, and they did have an adequate sample size for their primary outcome, which again was the symptomatic recurrent UTI. So the key findings here, as I'm sure you've heard before, the prophylaxis group had a 50% reduction in the relative risk of recurrent UTI. Now that sounds like it's really, really big deal, right? So we tell patients that sounds like, wow, 50% less chance of getting UTI. But actually, if you look at the absolute difference, it's not really that much. So it's 25% of the placebo group versus 12.8% of the treatment group. But technically that is statistically significant. As I mentioned, the occurrence of renal scarring was not different between the groups. And again, it could have just been because they were not adequately powered to look at that outcome. So interestingly, children with grades 3 or 4 reflux were more likely to have febrile or symptomatic occurrences than were children with grades 1 or 2 reflux. Now this is a question I've gotten in the past about this study is, how can we look at this study and try and risk stratify patients? Like, is there any indication of who would benefit more, from antibiotic prophylaxis, certain patients more than others? And I think the answer really is here on this slide. The answer is not, can't really say that certain people would benefit more, because they looked at hazard ratios, which are kind of like odds ratios in a survival analysis. And that's, they're basically their effect measure. And they consistently favored the prophylaxis group, no matter what, even if despite gender, no matter age at study entry, degree of reflux, whether they had 1 or 2 UTIs before they enrolled. And it didn't matter whether there was a Bactrim-resistant pathogen causing the first UTI. And it also didn't matter if the reflux resolved or not. So it seemed to favor the prophylaxis group for really everyone, regardless of their characteristics. Interestingly, they did do a little bit of a sub-analysis. They looked at children with baseline bladder and bowel dysfunction and children with a febrile index UTI, and they found that it was particularly beneficial for them. So that's your answer in terms of, risk, like who is most, who could benefit most from antibiotics. Perhaps you could say the children with bladder and bowel dysfunction and those who had a febrile UTI to begin with. Although that's a lot of kids actually who are, getting put on prophylaxis. A lot of them are presenting with febrile UTI. So I don't know that it's really all that helpful as far as risk stratification. So here's a nice graph. This is a Kaplan-Meier curve you may be familiar with. This is when we, do a survival analysis and kind of plot out over time the percentage of children with a febrile or symptomatic UTI. And one thing I think is very clear from this study, it doesn't even take a statistics degree to know that you can see these lines are diverging or going away from each other. And also that their confidence intervals do not cross, especially towards the end of that graph. So what about antibiotic resistance? So I want to bring this up because, again, this is kind of what is causing a lot of the controversy. There's also controversy about, as I mentioned, diagnostic criteria for UTI, et cetera. But we got to get this question from parents all the time, and I imagine that you do too. And I think it's a really important question that we should be able to answer for them. So they say to me, gosh, antibiotic prophylaxis, I just worry about their immune system. I worry they're going to develop, resistant bacteria. What about the side effects? There's a lot of very valid concerns I think that parents bring up. So it turns out their concerns are confirmed or validated by this study. So if you looked at the two groups, so in this, where I have the red circle here, of course, Bactrim on the left, placebo on the right there. When you look at antimicrobial resistance in the first recurrent or symptomatic UTI with resistant E. coli, clearly that was more common in the Bactrim group. They're more likely to have a resistant infection, 63% of the patients versus 19.3%. So it's kind of hard to argue with that. So the answer is yes, the child is more likely to develop antibiotic resistance if they're on prophylaxis. That difference was 76% of the trimethoprim group had resistant organisms versus 28% of the placebo group. Overall, the incidence of Bactrim-resistant recurrent UTIs was slightly higher in treatment group versus placebo. Interestingly, the proportion of the Bactrim-resistant UTIs decreased over time in both groups, and we're not really sure, why that happened. And you wonder if it has something to do with, perhaps non-adherence to the medication, but it wouldn't really make sense because that would only explain a difference in the medication group. So this is a graph looking at it in 6-month blocks. On the left, you see toward the beginning of the study in the first 182 days. And then you see towards the end, and clearly there's a high proportion of recurrent UTI episodes that were resistant to Bactrim. That's the white bar, versus further down the road there at more than 547 days on the right-hand side, there's just a tiny little white box there. And that's, again, looking at the proportion of resistant infections at that point in time. And then this is a graph showing resistance to other antimicrobial agents in those who had Bactrim resistance. So this is interesting. Now, one thing I think is interesting is that nitrofurantoin on the bottom red circle there had much less resistance. And that's interesting because I think the nitrofurantoin is concentrated fecally, so in the stool. In general, it has lower resistance rates. I actually really like it as a prophylactic agent. And if we choose to do that, patients, I'd recommend taking it with a crystal formulation because the syrup just really doesn't taste very good. It's actually one of the criticisms of the study, the fact that they chose the Bactrim rather than the nitrofurantoin, as the main agent. So some people have said that perhaps they should have used nitrofurantoin. Okay, so moving on. So among those in the Bactrim treatment arm, comparing those who had an index febrile UTI that was Bactrim resistant versus susceptible, there was no difference in the incidence of recurrent febrile UTI. So this refutes traditional teaching, which is the agent chosen for prophylaxis should be different than the one used to treat the index UTI. So that's not necessarily true. You could actually use the same agent for treatment of the UTI and then also for prophylaxis, essentially. So I think that's helpful to know. And then resistance patterns may be different when other agents are used. Again, as I mentioned, the nitrofurantoin. So you wonder what would have happened if they'd done this study with nitrofurantoin. Maybe they wouldn't have found this issue with the resistance patterns. So who may benefit from antibiotic prophylaxis? These are kind of the take-home points. Children with culture-proven febrile UTIs and grades 2 to 4 reflux. Now, I say grades 2 to 4, even though this trial technically looked at grades 1 to 4, because I'm not usually going to prescribe prophylaxis for grade 1 reflux if it's only into the ureter. And I think most people in practice would probably not do that either. What about non-febrile UTIs and reflux? So there's really no data to support that. And there's really, in my mind, no reason to get a BCUG. So I don't typically recommend working up patients. And this is something that you could say as part of your practice-based improvement, if you like, because I think that was one of the requirements of the talk. If there were one, 30-day outcome that you could change in your practice, I would recommend not ordering BCUGs if they don't have a culture-proven febrile UTI. So these non-febrile UTIs really don't require it. And then what about incidentally discovered reflux? No real data to support that either for antibiotic prophylaxis. So best agents, this is a somewhat complicated question. There's a lot of factors involved. This is, again, one of the objectives of our talk today. So another take-home point. Again, basically, Bactrim's receptor is always going to be at the top of the list because it was in the RIVER study, but it's not the only option. As I said, I like the nitrofurantoin because of that low resistance and the fecal concentration. The crystals are well tolerated. Again, that really needs to be for older children usually, so they can take it in yogurt. Although I just saw a baby in clinic earlier this week who was on the syrup and was doing okay with it. So, and then amoxicillin if they're less than 8 weeks old, of course, because of the concerns about connectors, as you know. I don't love amoxicillin, as you may have noticed in some of those graphs. It definitely has high resistance. So I try to get the patient off of that as soon as possible. And then cephalexin is an option. I've seen some patients on that, particularly if there's some Bactrim allergy or something like that. So as I mentioned, this study wasn't powered to detect a difference in renal scarring between the two groups. A trial that was adequately powered for this outcome would take 8,000 subjects, actually. So that's really not feasible. Now, interestingly, I was doing another literature search last night, and I found a study that was a kind of follow-up sub-analysis to the RIVER study done by some of the RIVER trial investigators. And they essentially had looked at all of the patients in the RIVER study who had follow-up DMSA scans, to look for renal scarring, and they looked at those with a new febrile UTI. And they did basically some fancy statistics, and they did something called a propensity score to try and control for confounding. So it's a little bit of maneuvering there. But interestingly, they did find that prophylaxis was associated with a decrease in new renal scarring and this subset of river patients. So kind of take that with a grain of salt. So I think there's probably something there. The actual study itself didn't show it, but like I said, the sub-analysis by the river study investigators did show some difference. Okay, any questions so far about the river study or reflux or prophylaxis? Nothing so far? Okay. I will keep going. So we will talk a little bit about antenatal
Can I ask
hydronephrosis.
one
Go ahead.
question?
Yeah.
I'm sorry, Dr. Chan. I just wanted to clarify. So if we have a youngster who has recurrent UTIs with no fever, there's no indication at all for VCUG if they're 3 or 4 years old.
Correct. Absolutely. Okay. Yeah. And that's, and I know this gets somewhat nebulous because I definitely, I have the same issues like, gosh, was that really a fever or really not? I would say in situations where the parent can confidently tell you, nope, no fever, I would feel very comfortable not getting a VCUG. Because, and we assume that's just going to be a bladder infection. Now, if they tell you, gosh, I don't know, it seemed like they were kind of warm, or maybe it was 99 or 100, not unreasonable, to get a VCUG if there's some doubt or concern. Or let's say if they tell you, there was a fever, but you don't have culture results available, oftentimes I will just go ahead and get a VCUG if I just don't think I can obtain the culture results. So I realize there's definitely some gray area there, but it's those cases where the parent says, no way, didn't have a fever, just some dysuria, incontinence, whatever, culture proven, I would not get a VCG. I think renal ultrasound, absolutely. That's where we start in urology clinic too. And if you want to just send them to us, we're happy to see them too. We can, do the workup, get the ultrasound, all that stuff too. Does that answer your question?
Yep.
Okay,
yep.
Great. Any other questions about reflux or UTIs or anything?
Yes, Dr. Chan, would like to know if they're already on prophylaxis of nitrofurantoin. If they have a UTI, you will just increase the dose to therapeutic from prophylactic dosing, and then do you reculture them after like 2 weeks or?
Oh yeah, great question. So you're saying
how long
do
you treat? Do you
if they're on the nitrofurantoin for prophylaxis and you get the culture results back and it's sensitive to nitrofurantoin, you certainly could. I mean, you certainly could use that as an agent to treat. I would certainly, you could look at your culture results and just see what it's sensitive to, and then kind of take it from there. I mean, according to the River study, there's really no reason, you can't just increase the dose to treatment dose. But I would just really base it on culture results.
I know that we don't with, just non-reflux UTI, but for those kids, if you don't, unless they still have a fever, you would not see them again. You just go back to prophylactic dose. Am I correct?
Agreed. Yeah, that's a great question. I've seen that, come up a number of times in practice too. The parent comes in asking, well, gosh, do we need to get another UA today? Or do we need to get a culture after treatment? I usually don't, assuming, of course, that symptoms have resolved completely. Now, if they're still symptomatic, I think that's another story. Absolutely, I would reculture them, but I don't see a reason to reculture. If their treatment course is finished and the symptoms are resolved, they're really back to baseline. I don't see really a reason to reculture there. Any other questions? These are good ones. Nothing. Okay.
One more. Sorry. One more.
Yeah, go ahead. Yeah.
I think Irene had asked too. So clarifying duration of treatment for afebrile versus febrile UTI in a reflux versus non-reflux patient.
So I don't believe that there are any differences in duration of treatment regard if there's reflux or not. Well, I guess you could argue that it's a complicated UTI. So, typically it's going to be about 7 days. I think it's what we mostly do. And, I don't believe the River study actually got into that specifically, but, so I suppose you could argue to treat longer, but generally speaking, I would say just the same.
Thanks.
Yeah, no problem. Okay, so let's talk about antenatal hydronephrosis. Okay, so as I mentioned, there's a couple of different grading systems which get a little confusing because they're not really implemented consistently, right, throughout the community versus, some academic medical centers, and there's even inconsistency across academic medical centers. So, but I wanted to just make everyone aware of these different systems because you may see them on reports that you get back. This was the I should say first one or the earlier version. This was the Society for Fetal Urology grading system for postnatal hydronephrosis. So this goes from 1 to 4, which you may have seen at some point in time. And this is a nice diagram from a review in Nature Reviews in Urology. So grade 1 is when the urine barely splits the sinus on the far left there. Grade 2 is a full pelvis with major calyces dilated. Grade 3 shows some uniformly dilated minor calyces and parenchyma is spared. And then in grade 4, there's parenchymal compromise, and the cutoff for that is it's less than 4 millimeters in thickness at any point in time, any point on the ultrasound. Okay, so there's a really helpful online web-based tutorial all about prenatal hydronephrosis called CEVL. It's CEVL by a pediatric urologist at Northwestern University in Chicago. And this is a diagram from his web-based tutorial. So he helps you to distinguish kind of grades 2 through 3. So it's whether the pelvis and major calyces are visible or versus minor calyces being uniformly dilated in 3. So that's the difference, is that the minor calyces are dilated. So the reasons to grade, basically, it correlates, we think, somewhat with stasis of urine and percent differential function. And so that helps us, in theory at least, decide when we're going to get a renal function scan. Although I will say the guidelines on this are very fuzzy, and it's really left up to clinician discretion in terms of when to get a renal functional scan. And that's not really the focus of our talk so much today. So there was a consensus statement, not really a guideline, but more of a consensus statement from the Society for Fetal Urology. And that's basically a subgroup of our national organization in pediatric urology that really focuses on these types of issues, particularly prenatal hydronephrosis. They looked at 704 studies, came out with a statement in 2010, and there's been some updates to this since then. They searched Medline and Embase and try to come up with the best available evidence for how to work these patients up after they're born. So these are their recommendations in this graph. And so they, at this point, they broke it down into mild, moderate, severe, based on the antenatal hydronephrosis, which is a little bit of a gray zone. And then they also had look at, in the third column, the results of postnatal ultrasound at 2 to 4 weeks, and then whether or not the patient needs a VCUG. And then finally, whether or not, what's the recommendation for follow-up ultrasound, which most people are going to need. So I broke this down into a much simpler version, which I prefer, and I actually use this in clinical practice. So again, this is hopefully something you can take away for your 30-day outcomes, or maybe it's a 90-day outcome, I don't know. So practice improvement, right? So this would be number 2 on that list. So if the postnatal ultrasound is normal, then the recommendation is not to get a VCUG at that point. Now, do they need a follow-up ultrasound? I would not, and I would not put them on prophylaxis. Now, one question, so this is, again, somebody who had some issue pre-antenatally, you get the postnatal ultrasound, it's completely normal. And this would be, again, at the appropriate time, which we usually recommend is at least 48 hours after birth, just to make sure they're not too dehydrated and whatnot. So that's pretty much a no-brainer. As far as the lower grades, again, this is based on this kind of older grading system. SFU grades 1 or 2 is considered to be on the more mild end of the spectrum. The recommendation is not to get a VCUG in those cases, although I will see sometimes patients do anyway. And again, this applies to more so unilateral hydronephrosis or bilateral on a girl. Boys with bilateral hydronephrosis are a different story because we worry about posterior valves. Okay. So in terms of follow-up ultrasound, yes, we would, even for mild cases, and the recommendation here is to get that in a year. Although I will say in clinical practice, just realistically speaking, oftentimes I will get that in 6 months because I'm able to schedule that out in 6 months and I don't want the patient to get lost. So I worry if I say to them, come back in a year, that they may not. So I don't necessarily, to be honest with you, follow this consensus statement recommendation. I'll usually just get it in 6 months just to make sure they're plugged into our system. And so then finally, SFU grades 3 or 4, again, getting into more of those moderate and severe grades. Yes, we do get a VCUG. If there is reflux, we continue prophylaxis, although as based on my previous part of the talk, that may not necessarily be necessary. And then if there's no reflux, then we go ahead and get a MAG3 scan. That's the renal functional scan where we're looking for drainage and function. And we typically get that follow-up ultrasound again about 3 to 6 months. And I would put that patient on prophylaxis. Although again, this is another area of controversy where there's very much kind of mixed evidence to support antibiotic prophylaxis and prenatal hydronephrosis. And we'll talk about some of the meta-analyses and kind of how the quality of the evidence is actually pretty poor. So it's hard to really make, informed decisions about that. But I think the biggest thing here for this, the big take-home point in terms of practice improvement is people with these very mild grades of hydronephrosis, again, unilateral or bilateral in a girl, SFU grades 1 or 2, and in the newer system, it would be the A1s. They really don't need a VCUG. Okay, so special conditions, as I mentioned, bilateral grades 3 or 4 hydronephrosis. I would even argue maybe bilateral grade 2 as well. Bladder wall thickening, dilated posterior urethra, bladder diverticulum, ureterocele, or decreased amniotic fluid. These people need a little bit more of an urgent workup. So renal ultrasound the first 1 to 3 days of life, VCUG in the first 1 to 7 days of life, and definitely prophylaxis. So the thing we're worried most about here again is posterior urethral valves in a male. Also, we've also seen in ureteroceles in males or females can actually cause bladder outlet obstruction. And certainly they can cause upper tract obstruction as well. So they require more involved workup. I would typically get this workup when the baby's in the hospital. So I would want to know what the story is before they go home. Certainly would not want to send a child home, and particularly in a boy where you're concerned about valves without completing this workup. So these are the ones we worry much more about. Okay, so this was a study that came out as a basically an update to this classification system. I mentioned this is called the urinary tract dilation classification system. This was published in 2014. Now I'm pleased to report that our wonderful pediatric radiologists at UNC use this system. Now I will say not everyone uses it. It's really inconsistent across the country. The reason why this was developed is that there really was kind of a lack of uniformity in grading. And so their hope of the developers was that we would have a more unified approach. The hydronephrosis, as I mentioned, kind of confusing terminology and kind of subjective if you just use words like mild, moderate, severe, which I did, obviously. Urinary tract dilation can fluctuate. It depends on hydration status, degree of bladder filling, etc. And there are other indications for underlying pathology. So one of the concerns about that SFU system, as I kind of mentioned, is that as you notice in that first graph I showed, it only is looking at the kidney. That's it. I mean, it's really just looking at, are major minor calyces dilated, how thick is the parenchyma, that's it. It completely ignores the bladder and the ureters. So this system, I would say the big difference is it's more comprehensive. It's looking more at the whole urinary tract. And it's looking at things like bladder wall thickness and ureteral dilation. So in theory, it's more comprehensive and hopefully better. So this is what the system looks like. This is based on postnatal presentation. And this is looking at more than 48 hours. What is the diameter, the AP diameter? And this is on the far right here, you can see these are the more high-risk patients. So they call their classification system goes from P1, which is low risk, up to P3, which is high risk. So it's kind of similar. If you want to liken this to the SFU system I mentioned before, I think of these P3 people as essentially being the grades, SFU grades 3 and 4, but also with a little bit of extra stuff thrown in. Like, for example, these ureters being abnormal, bladder being abnormal, parenchymal appearance being abnormal. That's kind of like an SFU grade 4. Parenchymal thickness being abnormal, again, SFU grade 4, and then peripheral calyceal dilation. So this is kind of like grades 3 and 4 with a little extra stuff about the ureter and bladder thrown in there. But it's essentially the same concept. These people are higher risk for significant pathology, i.e. obstruction. They need a little more careful attention and workup. Okay, so this slide goes into some more detail about the different parameters that they look at, including the AP diameter that's measured on transverse image at the maximal diameter of the intrarenal pelvis. They look at calyceal dilation. The parenchymal thickness is kind of a subjective appearance. In terms of parenchymal appearance, they're looking at echogenicity, corticomedullary differentiation, and cortical cysts. In terms of the ureter, the dilation of the ureter is considered abnormal. And again, in the bladder, they're looking for wall thickness and for the presence of a ureterocele and for a dilated posterior urethra. Okay, so let's see. So these are the recommendations. And I kind of like this because they talk about risk-based management based on the postnatal diagnosis. So it gets a little more into who's high risk, who's not, and then what do we do about it. So that's why I like this diagram, particularly on the right-hand side. Again, the people we worry more about are the kids with the P3, which are considered more high risk. The plan for them would be follow-up ultrasound a month. VCG is recommended. Antibiotics are recommended. And again, as I mentioned before, these functional scans or MAG3 scans, looking at renal function and drainage is at the discretion of the clinician. So this guideline is not very helpful in telling us when to get a renal functional scan. Although I will say, I think myself and my partners would, in most cases, would go ahead and get a renal functional scan in a child with P3 hydronephrosis. Okay, I think I just skipped ahead here. There we go. So let me go this way. Give me 1 second. Okay, so we will continue to use this system at Children's. Good news, we are evaluating our protocol, and we're going to be updating that in the next couple of months, and we will find some ways to disseminate that. I'll work with Dr. Lewis, and hopefully we can find a way to disseminate that to you guys in terms of having a little bit more of a defined protocol based on all this evidence that I'm presenting today. So a couple more things I wanted to talk about, and then we'll leave some time for questions at the end. There's a couple other studies that have come out about UTIs and reflux in children with antenatal hydronephrosis. So that's kind of combining all the things we talked about. This was a retrospective study with 760 children. They looked at the incidence of UTI and reflux in children who had mild antenatal hydronephrosis. And remember, the consensus statement was saying, you really don't need to screen for reflux in these kids, right? So for whatever reason, these patients did have a screening VCUG. 63% of them did, in fact. And interestingly, take home point here, only 1.7% of those screened actually had reflux. And they did not have UTIs either. Hydronephrosis worsened at only 3.3%. And of the 692 with follow-up data, only 3.3% had a UTI. Okay. So of the patients who had the reflux, though, none of them had a UTI, which I think argues against even getting a VCUG, as I mentioned, in patients with mild antenatal hydronephrosis. Again, that's one of our 30-day outcomes we're looking to improve. Okay, so the 23 patients with mild antenatal hydronephrosis and UTI, only 5 had significant pathology. So 2 with grades 4 to 5 reflux, 1 ectopic ureter, 1 UPJ obstruction. And you could argue that, why even get a VCUG as a knee-jerk response? You could just wait and see who has a UTI in this case, because those are the people who had any kind of significant pathology. They had a UTI as well. Okay, so that's, again, just kind of breaking down those. Again, the 5 people with a significant pathology who had UTIs are circled there at the bottom. All right, so this is another study that came out in 2013. This was on antibiotic prophylaxis for UTIs and antenatal hydronephrosis. They included children less than 2 years old who had antenatal hydronephrosis. There were almost 4,000 articles that they screened. 4,000 patients that they screened and 21 articles. Take-home point here, as I mentioned, 76% of these articles were moderate or low quality. That is unfortunate because it's very hard to make conclusions based on this data. But with that being said, take it with a grain of salt. Low-grade antenatal hydro UTI rates were similar regardless of antibiotic prophylaxis status. In other words, not a lot of evidence here to support using antibiotic prophylaxis in children with low-grade antenatal hydro. High-grade antenatal hydro, and again, I'm assuming they're going off of the old SFU classification system. This is probably grades 2 and 3. Patients on antibiotic prophylaxis had a significantly lower UTI rate than those who did not. But again, keeping in mind kind of low to moderate quality evidence. So in other words, there's some data to support antibiotic prophylaxis for more moderate or high-grade hydronephrosis. I think that would be the P3 crowd in our newer system. But again, this is low or moderate quality of evidence. Okay. So this was another study that came out, I think this may be our last one, a multi-center observational study based on a registry that the Society for Fetal Urology has started. So kudos to them. They have only 213 patients, though, in this study with a median follow-up of 12 months. So it's, fairly short follow-up, relatively small number of patients for this type of thing. 8.4% of them developed UTI. On univariate analysis, antibiotic prophylaxis was not associated with the development of UTI. Again, so no data is supported here, with the caveat being, again, small number of patients, short follow-up. On multivariate analysis, females had more than 8 times the odds of developing a UTI, which is not surprising. Finally, this is a study by my very talented colleague, Dr. Braga from Canada. He's from Ontario, I believe, who's done a lot of work in this area. He and his investigators in Canada, they tried to do a pilot randomized placebo-controlled trial. As you can imagine how difficult that must be. And they looked at the UTI rate in infants with grades 3 and 4 prenatal hydro, again, based on our old SFU system. This was from August 2010 to 2013. They screened 301 patients. They found 81 were eligible and only 46 of them agreed to enroll. Wow, that tells you how tough it is to enroll patients, particularly pediatric patients, in randomized controlled trials. Reasons for declining were parental preference regarding antibiotics, which, as you can imagine, there's some pretty strong feelings, lack of interest in clinical research. And so their conclusion was multi-center collaboration is needed. It certainly is. And that's, I think, the only way that River was successful, because they actually had so many sites throughout the United States. So take-home messages, finally, incidence of UTI and reflux in children with mild antenatal hydronephrosis is low. And asymptomatic mild antenatal hydro, again, in this case, it would be the P1 people. There's really no routine screening for reflux required. There's really no need for long-term antibiotic prophylaxis based on the available data. Those who subsequently present with a febrile UTI should be evaluated for reflux. There is some evidence to support antibiotics for reflux rather than for antenatal hydro. I'd say the evidence is stronger. Although, again, with the caveat being there's definitely concerns about antibiotic resistance. But at least the evidence is better in terms of efficacy for the reflux patients. So children with febrile UTI and grades 3 to 4 reflux may benefit. Certainly, as we mentioned, Bactrim is a reasonable option. We have the most data supporting it based on River. Again, I really like nitrofurantoin because of the low resistance rates. Children with SFU grades 3 and 4 hydro, or again, P3 in our newer system, they're most likely to benefit, but there's really a question about whether anyone benefits based on recent data. Okay, and that is all I've got. So I would be happy to take any additional questions. And I think we've got about 15 minutes, so we have plenty of time.
I apologize because you probably already said this, but for the babies in the hospital period that have the low grade prenatal hydronephrosis, when do you think is the ideal time to get that first ultrasound? Because I know if they're a little dehydrated in the first couple of days, it may give you a kind of a false negative.
You're absolutely right. So the traditional teaching and the urology textbooks all say wait till 48 hours because of this initial dehydration period, these immature kidneys, whatnot. I think in practice, though, realistically speaking, that can be really tough because I'm sure you guys were like, man, this family wants to get out of the hospital, especially with COVID. So I think if it's a case where, we're not particularly concerned about, significant pathology, like it's, let's say, mild antenatal hydro, as you mentioned, perhaps it's unilateral, honestly, they can wait as an outpatient. I don't think that has to be done in the hospital. I don't think there's a good justification to, hold them hostage in the hospital just to get an ultrasound at 48 hours. So there's two options really. Get the ultrasound a little bit early. So if maybe push it to 36 hours or something, or have them come back, in a week or a month as an outpatient. I don't think it's going to make a huge difference. If the family's worried and you're saying, well, you could, one option would be put them on prophylaxis just for like a week or two or a month and just until you get the imaging done. I think that's another reasonable option. I think a very short-term prophylaxis, is very minimal harm if there's just like logistical barriers to getting the imaging done. So I would say either have them come back as an outpatient, be option one, and they could do that in 7 days or a month. Option two, just get it done a little bit early if you can.
Okay, great. Thank you.
Mm-hmm. Any other questions? Those are great questions.
This is Emily. Thank you, Dr. Chen. That was a really helpful talk to go through all that data. I really appreciate it. I have a silly question that I've gotten a few times from parents recently, and I don't know if you know the answer, but I've had families ask if the VCUG is painful. And I don't have a great answer for that. They have a lot of concerns, especially their young babies. Like, am I going to put them through this painful procedure? So do you know anything about that?
Great question. I'm so glad you brought that up because we get that question all the time. So, and I have some suggestions about how to, address that. So I
Perfect.
would say now, full disclosure, I've never actually had a VCG myself, of course. However, from what I've been told, a lot of patients will experience some mild dysuria for about 24 hours, and that's really the main side effect. The other thing I will counsel them about is, that feeling of being just uncomfortable because the bladder's quite full. So the radiology tech tries to get the bladder really filled to capacity. And to get a good study, they need to do that. So they'll calculate their capacity, based on various formulas with their age, and they'll fill them all the way up. And so they're going to feel like, gosh, I really feel like I have to go pee. So there's that mild discomfort. And then there's that mild discomfort again from dysuria. Now, one thing we can do if a family is just like, if they call in and say, gosh, my child's miserable, we could give them a couple doses of pyridium. That's really helpful for dysuria. And that usually resolves very quickly. The other thing we do is just push fluids. So those two things. The other thing I will say, as far as dealing with anxiety and addressing that, I get that question a lot. I think that's kind of what you were getting at, right? It's not just the discomfort, but like the anxiety. Is that right? Yeah. So, I think it's somewhat age dependent, of course, child dependent. It's interesting. You mentioned the babies. I think it's actually the easiest in the babies, to be honest. They will fuss a little bit because they don't like being held down. And I've been there for some of these studies. I've actually, been in the radiology suite. But in general, they seem to do very well. We don't typically give them sedation. For the older kids, I do think it's honestly, a more challenging study to get done, particularly if they are, kind of school age, kind of like that 5 and up kind of age range. I do want to mention we have some wonderful options at UNC for addressing that in terms of sedation. And actually, we have more options here than where I previously practiced. So we have a wonderful, our head of pediatric radiology, Dr. Lynn Fordham, is fantastic. And I had a chat with her when I first started about the different options. So one of them I really like actually is they can give PO sedation kind of on the spot. Like you don't have to schedule that in advance. So they can just give them some Versed or something by mouth. If the child's just not doing well and they're very anxious, they can just say, okay, here's the Versed. So that I've had a lot of families give me really positive feedback about that. They said, wow, that worked really well. It really calmed them down. They got the catheter in. Once the catheter's in, everything's fine. So I actually would prefer that versus or maybe nothing. The other thing we can do, they are offering also nitrous oxide, according to Dr. Fordham, and that's a relatively new thing at UNC. So they can do that, just mask them for a little bit just to get the catheter in. Again, they can wake them up relatively quickly because they really want them awake and cooperative for the study. So there's that. And I think they may even have a more involved option as well, but I haven't had anybody else really offer that. So there's multiple levels of sedation they can do, and we can still get a good study. They also have, just a wonderful radiology team there. They're very skilled at placing catheters. And this is something they do literally all day long. And I try and reassure families like you're in great hands. This is what people do every single day of the week. So I think they've had overall, really good experiences. And we also, Dr. Fordham also says they recommend that the parent just has a bunch of videos loaded on the iPhone just to distract them. So distraction is another really big thing. And just talking to them in advance. I actually also developed a patient education handout in Epic. So I have a smart phrase, and I'll put that in their after visit summary when they see me, and it goes through. I think it's actually, to be honest with you, I think it's actually from HealthWise, and you may be able to find it in Epic, but it goes through all of the what to expect on the VCUG day, what to expect afterwards. I like trying to do that counseling in the clinic, and then also give them the handout, before they have the study done. So that seems to be working pretty well.
That's great. And go ahead.
Dr. Chan, in terms of those, child life specialist or sedation options, are they only at Chapel Hill?
Yeah,
That's
it's only at
true.
Chapel Hill as far as I know. Yeah.
So no, you guys don't do VCUG anywhere in Raleigh, am I correct?
I don't think so. No, to be honest with you, I'm new, and also the radiology situation here is a little bit complex. I've tried my best to wrap my head around it. I believe that you guys, now, Dr. Lutz, you can correct me if I'm wrong, but I believe they're offered at Rex, correct?
They are. The pediatric radiologists who work at Rex will do the VCUGs. Sometimes it takes some coordination because they come from across the street in their outpatient clinic. So if you have a patient who needs one, I'd recommend reaching out to them to try to coordinate just so that they can do it in between their scheduled cases or just know that that patient is needing one. But I would say during the week, non-holiday business hours, they can do them.
They could do them. Yeah. I don't think they're doing sedation. Is that correct? That was my
No,
understanding.
I don't
Yeah.
think so. I don't think so.
Yeah. So, and that's probably fine for the majority of patients, to be honest. And we actually prefer no sedation from the standpoint of like study quality. I think for babies, absolutely fine. I would not really give a baby sedation ever. It's usually the older kids are need that. So if you're like, again, pediatric hospitalist kind of situation, if you're seeing a newborn and you want to get a VCG before the discharge, absolutely reasonable. Just get it at Rex if you want to. Yeah.
Right. No,
Yeah.
I was just going to comment. In the long ago, when the VCUG recommendation was different, the under 2 but after 9 months, that age group is so stressful for the parents, or just below 3 years of age. It's so stressful for the parents when they get VCUG. So I just thinking that if there's some more easier options for them, but that's great. Thank you very much.
Yeah, of course. Yeah, that's all. That's what we have available. I wish they had more options in terms of locations. I have a lot of families ask, but unfortunately, they're just concentrated in Chapel Hill. But like I said, I think they do a great job, and they do have a lot of sedation options available. I know it's a very stressful study. I don't take that lightly.
And we have another question in the chat. If a newborn infant may need a VCUG, do you recommend waiting until after VCUG to do the circumcision?
Oh, great question. Not necessarily. I think you can certainly go ahead with the VCUG, assuming they are pretty accustomed to pulling back the foreskin and getting a catheter in, even though of course it's going to be a little bit tight. But I would say either one. I don't think there's any reason you have to wait until after circumcision.
That's good.
Oh, the thing I do want to mention, I think Dr. Chow, I think it was kind of mentioned in passing those the guidelines for imaging after febrile UTI. That's a question that comes up a lot, actually. So as you probably know, the AAP changed their recommendation, to being after the second febrile UTI. I didn't really get into that in this talk. But I do want to mention that I think in practice, I will mention that to families and just trying to have like kind of a shared decision-making discussion with them about, well, here's the guideline, but it is also somewhat controversial. There was controversy about the way that guideline was developed, how the criteria weren't as stringent in terms of inclusion and how the UTIs were diagnosed, et cetera. And I kind of talk to the families about how concerned they are, whether they're willing to take their chances on getting a recurrent infection versus they just want to have an answer. And so I tell them the guideline exists, but honestly, I kind of talk it out with them and see what they want to do. And some people just say, listen, I'm worried. I want to know this was a severe infection. My child was hospitalized or whatever. I want to know if there's reflux there. And I think that's totally reasonable just to go ahead and get a VCUG. I don't think that you have to stick necessarily to that guideline if the family feels otherwise. I think that's reasonable, in other words, to go ahead after that first infection, particularly if it's a more severe infection, like something that requires hospitalization. Any other questions?
Dr. Chan, it's Ashley Wallace from UNC.
Oh,
How are you?
I'm fine. How are you?
Good. I had asked that question about the circ. We tend to delay the circumcisions until after they've had a VCUG just
Oh,
because we
okay.
are worried about pain in the baby with a freshly circumcised penis. Do you think that that's a reasonable practice? It does kind of interfere with discharge timing sometimes. So just trying to figure out what the best practice is there.
Yeah. What was the concern? I'm sorry, with having them not be circumcised and doing the VCG?
Or no, we wait to circumcise until after the VCUG because of concerns that the infant might have more pain with the VCUG with a freshly circumcised penis. But I don't know if if there's any real evidence to support that. Just
Yeah,
kind of
that's an interesting question. No one's ever asked me that, huh? And I did not know that was happening. So thank you for sharing that. I would say I don't see any reason why you have to do that.
Okay.
Because with the circumcision, it's interesting. I get this question a lot from parents about, circumcision we do in the OR. Well, is my child going to have trouble peeing afterwards? And the answer is, well, they shouldn't, because we're not doing any actual work on the urethra at the time of circumcision. I mean, I usually describe it as kind of like a skin level procedure. You're just kind of removing some skin. But I don't see a reason why you couldn't. I mean, have a circumcision, and then do VCUG, because you really shouldn't be touching the urethra. So there's really no reason they can't just put a catheter in. I mean, if anything, maybe it's a little bit easier for them. They don't have to pull the foreskin back. Like, there's the urethra right there. And I think, most cases they should be able to just slip a catheter in pretty easily. I wouldn't have any particular concerns, regarding healing of the circumcision or something like that. As newborns heal so easily; it practically seals up, and in 5 minutes. So I think it's fine if you wanted to do a VCUG after circumcision, if that's going to help your workflow and make discharge more efficient. It seems like that's a worthy goal that would make everyone happy, including the parents, right?
Right, for sure. Okay, thanks.
Mm-hmm. Let me know how it goes if you change.
Boo.
Yeah, please do. Keep me posted. Hopefully it goes well. I don't see any reason why not. Are you based at UNC in Chapel Hill, or are you at Rex?
Yes, I'm at UNC in Chapel Hill.
Oh, okay. All right, great. Maybe I'll see you around sometime. Are you a pediatric hospitalist there?
I'm a nurse practitioner.
Wonderful. Okay,
I
great.
met you with one of our babies recently. But yeah, I look forward to talking to you about updating our protocol
I think I knew that
for
was.
hydronephrosis. Yeah.
Oh, great. I think I know who that was. Okay, wonderful.
Yeah.
Nice to see you again.
Good to see you. Sorry, my video's off. I'm in
That's
rounds.
okay. No worries. It's okay. It's a 2021 thing. Any other questions? I think we're right at just about 9 o'clock. So that's great.
Well, thank you so much. Really appreciate it.
Yeah,
Thanks
my pleasure,
for
Dr.
joining
Lewis.
this morning.
Yeah, thanks for having me. I really appreciate it. Everybody have a great day. Please reach out if you have any other questions.
Sounds great. Thanks.
All right. Take care. Bye.
Bye.